Bismillahirrahmanirrahim. Today inshallah we will be learning about diagnostic imaging. Since I will be focusing in this lecture how to answer in your OSCE stations whenever you come across any imaging study. So I would recommend to please go through these terms because these terms are very useful whenever you have to write down about your findings. When you will use these specific terms to describe any specific diagnostic imaging, then you will get full marks. Since you have already attended radiology lectures and you are already familiar with these terms, so I'm not going into the details, but this is just a reminder that you must use these specific terms while describing your findings. First, I would like to talk about the ultrasound frequency. Ultrasound frequency is very important to understand because there are, if we divide in basically two types of frequency, high frequency and low frequency. The higher frequency ultrasounds are good for superficial structures. For example, if you have to do the ultrasound of the breast, in that case you have to go with the higher frequency ultrasound because the higher frequency ultrasound does not go into the deep structures, okay? While if you have to do the ultrasound of deeper structure, for example abdominal viscera or pelvic viscera, in that case you need to go with the lower frequency ultrasound, which actually has more depth than that of the higher frequency ultrasound probes, okay? Then there is another very important concept about the modes of the ultrasound. Basically there are two main modes, the grayscale mode and the Doppler mode. So here we will be talking about the grayscale mode. In grayscale mode there are three main types, A, B and M. Okay, so A mode is basically for amplitude. A stands for amplitude. So A mode ultrasound is not very frequently used. Basically this is used, for example, as you can see here in this slide, this may be used to check the diameter of the eyeball, for example, or to check the size of the lens. So that is basically used for measurement of the size, okay? And then there is B mode ultrasound. B mode, this is the most common one that we use. This is basically, B stands for brightness mode, and whenever we are giving you the ultrasound at your level, that would be B mode ultrasound. So if we are asking you which investigation is this, so you can write down grayscale B mode ultrasound, okay? Because that is included in your syllabus. We are not giving you the A mode or M mode. What is M mode? M stands for motion. So that is for the motion purpose. If we need to check the movement of something, for example in this case you can see here that this is the mitral valve, okay, and this is an imaginary line, and we are checking the movement of this mitral valve. So here what is this? This is basically the movement of this mitral valve, okay? So that is motion mode, okay? This is also not included in your syllabus. So whenever we are giving you the ultrasound picture, so you can easily write down the grayscale B mode ultrasound, okay? Now what about the CT scan brain? CT scan brain, that is included in your syllabus. That is basically CT scan brain for the trauma. And you know that for trauma we are using CT scan plane, that is without any contrast. So you must write down whenever we are asking you about the name of the investigation, along with writing down the CT scan brain, you must mention that this is without contrast. for your syllabus I'm telling you, because there may be with contrast or without contrast, but in your syllabus, since we have included only the CT scan brain for trauma, and in trauma we are doing CT scan without contrast. Okay, so this is the orientation, so that you can easily write down your findings, which part is the anterior, which one is the posterior, and not only this, but also you must mention which plane we are showing you. So I must tell you that mostly we are giving you the axial plane. Okay, axial plane CT scan we are giving you in your exams. Okay, coronal plane and sagittal plane, these are not very frequently used for your exams purposes. These are different brain windows. Okay, and this is brain window and this is bone window. So for your exam purpose we are using brain windows. So whenever you are describing your investigation, all these things you must mention. Okay, this is very frequently used in exam, and in this case you can see here that there is defect here. This is lens shape na. So and this is hyper dense. Okay, why this is hyper dense? Because this is more whiter, because you know that bone is the most hyper dense thing that we can see on CT scan, and you can see here that this is more whiter than blackish. Okay, so this is hyper dense. Okay, no, not only that, you have to tell us the density. Along with that you must also mention the shape. Okay, and location. And remember that acute hematomas are always hyperdense. If these become subacute or chronic, so these may become isodense or even hypodense. Okay, this is also one of the examples of acute extradural hematoma. And how can you recognize that? Because of its shape. This is a lens shape. And why this is lens shape? You can see here that these are the sutures, and because of these sutures, since dura mater is attached with the sutures, so the hematoma is limited. Okay, if you remember the names of the sutures, then you can just mention, otherwise better to avoid if you don't remember exactly. Other thing is that sometimes there are associated findings as well. In this case you can see that there is some edema of the soft tissue. You can just also write down this, but remember that you must write down the main findings first. Okay, and the other thing is that if you can see that there is a midline shift, you may write down this, but if you are not sure, so please avoid it, because then there may be deduction of marks, because actually you can not measure the midline in these pictures. Okay, these are measured on the standard CT scan pictures. So we are not providing you the standard CT scan pictures in your exam. So at that level it will be very difficult for you to measure, and if this is very significant change, then you can just write down that there is midline shift. Acute subdural hematoma, and here you can see the shape is crescent shape. And why this is crescent shape? Because this blood is spreading over the surface of the brain. Because of that, there is no limitation and it is spreading. That's why it gets the shape of some crescent. Now chest imaging. In chest imaging, just remember that you should also write down X-ray chest, PA view, or X-ray chest, AP view, semi-erect or supine. Okay, so what is the concept of the PA view? Basically what happens that rays are coming from the back side. Okay, and you can see in that case we have to maintain the position of the arms. so that the scapulae are away from the lung fields. Okay, and that is the reason that in these x-rays the scapulae are away from the lung fields, while in AP view, in this AP view, actually these are for the trauma patients, for ICU patients, for any patient who cannot stand, we have to go for the AP view. Okay. In these we may not maintain the position of the arms, but usually these arms are by the side of the patient. These are not in exactly in this position. Okay, that may be the reason that in AP view the clavicle appear a bit straighter. Okay, but that depends on the position of the arms. Okay, and that may be the reason that scapulae are usually over the lung fields in the AP view. So let's see the differences here as well. You can see here in this PA view picture that scapulae are away from the lung fields. Okay, while here you can notice that this is the margin of the scapula. You can see this is over the lung field. Okay, and scapulae a bit straighter than that of the PA view. Other thing is that very important that heart shadow appears larger. Heart shadow appears larger in the AP view. Okay, and the other thing is that you can see that the lung appears a bit lighter in AP view, and sometimes it is felt that there are some infiltrates, although these are not the infiltrates, and that is the reason that PA view is preferred over the AP view when we have to study the pathology of the lungs. Okay, but sometimes we cannot do that because the patient is very ill, cannot stand. In that case, we have to go with that of the AP view. This is the tracheal anatomy. You can see the trachea is central. From here you can just trace from the spine that the distance is equal, but when you are just going down, just notice it is a little bit towards right side. Okay, in this x-ray you can see that on the right side you cannot see the image of the lung. Okay, here this is very clear. Okay, that there is lung present, but here you cannot see. This is opacified. Okay, or hazy. Why it is so? Because there may be some fluid. Whenever we are talking about fluid in case of surgery, we are keeping the thing in mind that this may be of the trauma. Okay, because pleural effusions we are not giving you any exam because that is covered in medicine. Okay. So in surgery we are more relevant with that of the trauma cases. Okay, so in this case if you see that you cannot see the lung fields and this is hazy or opacified, then you must think about the blood. And in this case you can see that this is basically AP X-ray. Why we are saying that this is AP? Because the patient is lying down. Why we can say the patient is lying down? Because there are two things. Number one, if there is fluid and patient is standing, so there must be some air fluid level that we cannot see here. Okay, other thing is that usually there is gastric bubble seen when the patient is standing, that we cannot see in this picture. Okay, so that's why we can say that this is AP view. Okay, and what is our diagnosis? That this is left-sided hemothorax. Okay. Okay, in this picture you can also see the exactly the same thing, that the right side of the lung you cannot see, while the left side it is very clear. Okay, so on the right side there is opacification. Okay, the complete opacification, you cannot see the lung. Okay, and you can notice the lung margin here. Okay, if you are very carefully noticing, you can see the lung margin, that is the collapsed lung. And why this is collapsed? Because of the hemorrhage. Okay, so this is basically hemothorax, and this is again AP supine. Why we can say that AP supine, although in this we cannot see the clavicles straighter, these are more slant, okay, you can see, but even then we can diagnose it as the AP supine. Why? Because we cannot see the gastric bubble and we cannot see the air fluid level here in this hemithorax. Okay, other associated finding, you can see the hyperdense mark here. This is of the shape of the bullet, so we can say that this is the bullet, and that means the hemothorax is secondary to the gunshot injury. Okay, but remember that always write down your primary findings first and then the associated findings. Okay, then in this picture, what do you notice? You can see here that there is air fluid level, okay, and you can also notice the gastric bubble. So in this case, you can say that this is erect picture or semi-erect picture, but this is AP. Why AP? Because you can see here the scapular margins, okay, very clearly. Okay, you can see the scapular margins very clearly, so that is AP erect. Okay, the other very important thing is that since there is air fluid level, and we have told you earlier that in trauma cases, whenever there is fluid, that is blood until proven otherwise. So we have to think about hemothorax, but along with that, you can see here, just focus on this part, that here you cannot see the bronchovascular markings. Okay, you can just compare, because these are the bronchovascular markings, these are normal bronchovascular markings. Okay, and you cannot see bronchovascular marking in this peripheral part. Okay, so this tells us that there is pneumothorax. Okay, that is air present in the pleural space. So along with the blood, there is air. So this is basically pneumothorax, okay, on the right side. In this picture, you have to just focus on this side. If you compare this with that of the left side, you can notice that they are here on the left side, normal bronchovascular markings are present. Okay, but these are not very clear. Why? Because this is AP X-ray. In this AP X-ray, as I informed you earlier, that usually it is not very clear, and sometimes it feels that there are some infiltrates. But since we are related to the trauma, so you can see here that in this lung field you cannot notice any bronchovascular markings. Okay, this is smooth black, है ना? So that's why you can say that since there is no bronchovascular marking, so this is basically pneumothorax, and even you can notice the collapsed lung. Inshallah, in the next slide, I will tell you how to write down the findings clearly in your exam. Let's see. Other important thing is that this is AP X-ray. Why AP X-ray? Because you can notice here the scapular margins, okay, and the clavicles are a bit straighter. But why upright? Because you can notice the gastric bubble. So this is AP but upright. Okay, and now notice how we have to just write down if we come across pneumothorax. So for example, I have just written here that visible visceral pleural edge is seen as a very thin sharp white line. No lung or the bronchovascular markings are seen peripheral to this line. peripheral space is radiolucent. This is the specific term that we have used. Okay, peripheral space is radiolucent compared to the adjacent lung. Lung may completely or partially collapse. That depends. That is completely collapsed or partially collapsed. In the previous slide, we have seen the lung that was completely collapsed. Okay, so if that is completely collapsed, you have to write down that is completely collapsed. Okay, mediastinum shifted towards right or left. Naturally, that depends on your specific investigation. In case of tension pneumothorax, if that is plain pneumothorax, so actually mediastinum remains at its own place. Okay. Okay, in this slide you can see that on the left side the lung is completely collapsed. Okay, and peripheral to this line you cannot notice the bronchovascular markings which are visible clearly on the right side. Okay, so that is basically pneumothorax, but in this case you can also notice that trachea is going towards right side and slightly mediastinal shift. So basically there it is starting of the tension pneumothorax. Okay, in this you can see that there is collapsed lung. Okay, but this is not completely collapsed. But even then, if you notice that mediastinum is shifted towards right, from here also you can notice the trachea is towards right side. Okay, and mediastinum from here you can notice this how much it has gone towards the right side. So basically this is tension pneumothorax. And what is the view? This is basically AP view supine. And how can you say that this is AP view supine? Because you can see the scapular image here over the lung field. Okay, other thing is that why it is supine, because you cannot notice the gastric bubble. Okay, so this is basically tension pneumothorax. Whenever we are talking about thoracic trauma, remember that chest intubation triangle, that is triangle of the safety, is very important to remember. What are the boundaries? This is very frequently asked question. And how the chest tube is visible on the X-ray, you can notice here that there is a tube on the right side. And remember that always with all such tubes there are radio opaque markers. You can notice here a darker line. Okay, radio dense line. Why? Because there is a radio opaque line. Because if there is no radio opaque line, then it will be little bit difficult to trace the tubes. So with all tubes there are radio opaque markers. And you can notice here that there is some breakage in this radio opaque line. Why there is breakage? Because this is opening. Okay, when there is opening, that's why through that air or blood is passing out. Okay, and along with the chest tube you can notice here that the lung is partially collapsed. Why we can say that lung is partially collapsed? Because you can notice here in this part that you cannot notice the bronchovascular marking, while the bronchovascular markings are quite visible in the lower part. So basically what happened, that the doctor has passed the chest tube because of the pneumothorax, and now the lung may be expanding because of the chest tube. And now you can see that there is still pneumothorax present. It has not completely resolved. Okay. Okay, so this is also very important X-ray. In this you can notice that the level of the diaphragm on the left side is quite higher up. And why it is higher up? That may be because of the diaphragmatic injury. Okay, There may be different ways that diaphragmatic injury may present on the X-ray. Number one, that there may be difference in the level of the diaphragm, okay, and the other thing is that there may be any abdominal viscera that is present in the thoracic cavity. As you can see here, here in this picture you can see that gastric bubble is not at its normal place. It is present in the thorax. Okay, why in the thorax? Because when there is diaphragmatic injury, because of that the abdominal viscera may herniate through that defect into the thorax. And along with that, you can also notice that there is obliteration of the costophrenic angle. There may be some pleural effusion as well along with this, okay. And which type of X-ray is this? This is basically AP erect, okay. Why erect? Because you can see the air fluid level here, okay. Okay, another thing that I wanted to tell you, because there are two ways I have told you how the diaphragmatic injury presents. Other way that you can notice the diaphragmatic injury, for example, if you have passed the nasogastric tube, so this nasogastric tube may be visible in the thorax, okay, because that may be coiled up here. If you have passed the nasogastric tube, that won't be at its normal place on the downside. So by that coiled nasogastric tube into the thorax, you can also say that there is diaphragmatic injury and the stomach has gone up into the thorax, okay. Okay. So in this X-ray, although the lung is okay, there is no problem that we can notice here, but you can notice that there is some free air under both the domes of diaphragm. But since on the left side there is already a gastric bubble, so there is a little bit confusion. But here just focus on the towards the right side. Here you can notice that there is air just below the diaphragm. So basically this is pneumoperitoneum. And why there is pneumoperitoneum? Not only the visceral perforation, but for example, if there was any laparoscopic procedure or hysteroscopic procedure, there may be air that may remain 1 week or 10 days, okay. So that shows that whenever you have to diagnose pneumoperitoneum or any visceral perforation, you should ask for the X-ray chest, not X-ray abdomen, okay. Now the abdominal imaging. In abdominal imaging, very commonly we are giving you the bowel obstructions, and how do you diagnose that whether this is a small bowel obstruction or large bowel obstruction. You can see the central distension in the small bowel obstruction along with the valvuli conniventis, and not necessarily valvuli conniventis. There may be featureless dilatation. That featureless dilatation may also be present, but most commonly you come across with the valvuli conniventis or the stacks of coin. I will just show you in the next slides inshallah, and the step ladder like dilatation, okay. While in large bowel obstruction, this is usually peripheral dilatation. People usually call it picture frame dilatation, okay, because this is on the peripheral sides. Other very distinguishing feature for the large bowel obstruction is the presence of haustra, okay. So we will see in the next slides, okay. In this small bowel obstruction, you can notice these stacks of coin picture, okay. This is basically called as the valvuli conniventis. You can just notice that these valvuli conniventis are through and through, okay, and equidistant, okay, equidistant and through, okay. So this shows that this is valvuli conniventis. Here also you can notice the valvuli conniventis, okay. These are through and through. You can see. Okay, you can trace throughout the diameter of the bowel. Along with this, you can see some hyperdensity that may be artifact. Because of its shape, we can say that this is artifact. If there is any associated finding, you can just write down, but first you have to focus on your primary finding. Here you can see the small bowel obstruction, and basically this abdominal x-ray has been taken in erect. Remember, in your exam we are just hiding these markers, okay? So you cannot rely on these markers. You have to just rely on your findings. According to the findings, you have to decide whether this is supine x-ray or the erect x-ray. In the previous x-ray, you can see that there was no air fluid level, okay? Because of that, you can say that this is abdominal x-ray plain AP supine, okay? This is supine picture, while here this is AP picture, but that is erect. Okay, so you have to mention always that whether this is supine or erect. And how can we just say that this is erect? Because there are air fluid level. And even remember that whenever we are getting abdominal x-ray AP erect, we have to ask the patient to stand for few minutes, 3 to 5 minutes, because air and fluid, it takes time to separate. So if we are just asking the patient to stand up and instantaneously we are taking x-ray, so we may not find so many air fluid levels, okay? So this is basically erect picture. Here you can see there are various air fluid levels, and this is basically called as the step ladder pattern, because this is just like a wooden ladder in which there are different steps. So here you can see also that there are different steps. So this is called as the step ladder pattern. This is the x-ray abdomen, in which you can see the dilatation that is quite peripheral, and this is much wider than the previous one. In the previous one, you can just notice this is the dilatation, okay? But just notice the diameter, while here in this diameter is much larger than the small bowel, okay? So basically this is large bowel, but along with that you can just notice the haustra, okay? You can see that haustra these are incomplete, okay? Haustra are always incomplete, while here valvuli conniventus, just notice that these are complete ones, okay, through and through, okay? Once started from here, it will be ending here, while in haustra this is not complete. You can notice here, okay? These are the haustra, okay? So this shows that this is the large bowel obstruction, okay? Okay, this here also you can notice the diameter, how much large it is, but as I have mentioned earlier, that you cannot measure with the film that we are providing you, so we don't expect the measurement actually. Just you have to notice visually that this is much larger than the small bowel diameter, okay? And the presence of haustra you can see, so this shows basically the large bowel, okay? Here there is a very specific picture. You can see here that there is a very specific picture that shows like coffee bean. That's why this is called as the coffee bean appearance or coffee bean sign. Basically this is present in the volvulus. This volvulus may be a sigmoid or the cecal volvulus, but remember that sigmoid volvulus is much more common than that of the cecal volvulus, okay? And what is Freeman-Dell sign? Basically you can see that one line is coming from here, one line is coming from here, one line is coming from here, and all these three lines are just merging at a single point. That shows that there is twisting, okay? So this is basically called as the Freeman-Dell sign, that merging of three lines, 1, 2 and 3, all these three lines are merging at a single point. This is called as the Freeman-Dell sign, and that shows that there is some twisting. Along with these main finding, you can also see that there is some highly radio dense object present. This is basically the Austin Moore prosthesis. There may be some fracture previously had of the femur, so that's why that has been replaced. Okay, so but this is a secondary or the associated finding. You may write down, you will get more marks, but remember, don't lose your focus from your primary finding. This is basically target sign. And why do we call this target sign? Because you can see the one ball and there is another ball inside. This is basically ultrasound picture target sign. You can find in the CT scan and the ultrasound as well, but you cannot find the target sign on the X-ray. Okay. Barium studies, these are very frequently asked studies in your exams. Okay, so basically when you see the barium in the esophagus, so you have to write down that this is barium swallow or barium esophagogram. Okay, that is for the X-ray that you have to write down. And whenever you are just studying the barium, actually in practical life we cannot diagnose anything on a single X-ray. Whenever we are doing these barium studies, we are just making diagnosis on the multiple X-ray films, but naturally in your exam we are giving you a single film, so you have to decide on that single film, but that is with the finding. That's why only with only single film you have to diagnose. Remember that whenever you are just looking for the barium, notice how it is ending up. Okay, now this is smooth. Okay, very smooth. So in that case you have to mention. Okay, for example, that you can just write down that this image shows a markedly dilated esophagus with smooth narrowing of esophagogastric junction or lower esophageal junction, forming bird's beak appearance. Okay, so that is very important, that you have to tell us that there is a smooth narrowing. Okay, this is a smooth narrowing. Okay, because when you are talking about a smooth narrowing, that means there is some benign finding. While you can see in the other picture here, when you are just writing down your finding, okay, this is dilated esophagus, but along with that there this narrowing is not a smooth narrowing. Okay, this is very irregular narrowing. Along with that there is shouldering. This effect is called as shouldering. So you can just write down that there is irregular narrowing at the lower esophagogastric junction along with the proximal shouldering. This is very important word that you have to use, because that will tell us that you understand about the malignancy, because this is a malignant lesion. Okay, while here there is very clear that there is no malignancy, rather this is a benign lesion. This is basically a marker, maybe the radiographer has put, because if the patient is complaining that I have problem here at this site and I have some stickiness and there is some difficulty in swelling at this region, so the radiographer has put this marker so that we can assess where is the problem actually. This is barium enema. How you can say that barium enema? Because you can see the rectum and the sigmoid and the descending colon, transverse colon, ascending colon and the C cup. Okay, so this is basically barium enema. And you can notice in this barium enema that on the here sigmoid colon and descending colon and even a distal transverse colon, you cannot notice the normal presence of hostra, while these hostra are present on the ascending colon. Okay, so that means there is loss of normal hostra, that is leading to the lead pipe appearance. Okay, This is also barium enema, and basically this is a very magnified view. Actually, I just want to show you the apple core appearance. That is actually the irregular narrowing, okay, along with the shouldering, exactly as we saw in the barium esophagogram, that there was irregular narrowing with shouldering. That was significant because that may tell us about the malignancy. So here exactly the same, the apple core appearance, that is usually very suspicious finding, because that tells us that there may be malignancy. Okay. Hepatobiliary imaging, in this ERCP, actually I have just written ERCP, you have to write down the, along with ERCP the full version. Okay. And here, how can you just tell that this is ERCP? Always with the ERCP there will be endoscope present. So this is basically endoscope. So with this you can diagnose that yes, this is ERCP going on. And here what are the findings? Basically you can see this is the CBD. Okay, this CBD is markedly dilated along with some filling defects. Why there are filling defects? And you can notice that these filling defects are smooth. Okay, multiple and smooth filling defects. And why these are present? These may be because of the stones. Okay, so actually this CBD seems full of stones, that is choledocholithiasis. Okay, this is PTC. Here, how can you say that this is PTC? Because there is no endoscope present and there is presence of this needle. This will always be there. So with this, with the help of this, you can say that this is PTC. And in PTC you can notice that we can see the intrahepatic ducts, and you can see these all are dilated. Okay, the intrahepatic ducts all are dilated. And along with that you can see that there is some narrowing. Okay, some narrowing present at the junction of right and left hepatic ducts. Okay, and you can see that this is smooth narrowing. Okay, tapering is smooth. Okay, this is not irregular, but yes, there is some narrowing present. CBD seems normal. Okay, so you have to mention where is the narrowing and how is the narrowing, because this narrowing is smooth, so seems to be a benign structure. Okay, but if there is a differential diagnosis you are asked, so you can just write down this is the structure that may be benign, number 1, and number 2 that may be malignant. Okay, so this is ultrasound, and here you can see this is hyperechoic. Why hyperechoic? Because this is bright, this is much more whiter. Okay, and along with this you can see this is post acoustic shadowing. Okay, since the shape is that of the gallbladder, and here you can see some hyperechoic lesion with post acoustic shadowing, so your diagnosis is choledocholithiasis. Okay, here also the shape is that of the gallbladder, and there are 2 hyperechoic lesions and along with the post acoustic shadowing. Okay, so this is basically choledocholithiasis. Whenever there is acute cholecystitis, so these may be the findings. This is the picture that depicts. Okay, and in real ultrasound picture you can see like this, but as I mentioned that you cannot measure the thickness in the film that we are providing you. So in that case, if you have to diagnose acute cholecystitis, so you have to check the pericholecystic fluid. Okay, if there is pericholecystic fluid and a stone is stuck at the neck, then you can just diagnose acute cholecystitis, because measurement is difficult in the film that we are providing you. Usually we are providing you on the X-ray film, the ultrasound on the X-ray film, so naturally that is really difficult for you to measure. Okay, so these are the findings for the acute cholecystitis, and if you are confused, so no problem, just write down at least choledocholithiasis, don't forget about that. Okay, About the cystic echinococosis, this is very important. I think I have talked about this earlier in my lecture on the hydatid cyst, that you must also mention these gradings. Okay, this is very important, that if you just see, and along with this you are mentioning that CE1 or CE2 whatsoever, then you get full marks. Okay, for example, here you can see, and you can notice that I'm telling you the specific signs as well, along with all the ultrasounds and all the x-rays. So because these specific signs, these are important in your findings. Whenever you are just writing down your findings, if you are using these specific signs, then you are getting full marks. Okay, this is water lily sign. Here you can see, basically this is an anechoic lesion in which you can see the floating membranes. I will just tell you how to write down in your findings, okay, in the next slide, inshallah. Okay, for example, I have just wrote down here a well-defined anechoic lesion with low-level internal echoes. The cyst shows a detached, irregular, laminated membrane inside it, which appears to float within the contents of the cyst. This is water lily sign. And what is your diagnosis? Hydatid cyst. And what is the stage? So you have just written the stage. So just like this, we are asking you in your exam, so you can just write down like this. Okay, this is just an example. Okay, here also you can notice water lily sign is present here in these, but in this actually no water lily sign. This is completely anechoic, so CE1. Okay, while this is CE3. Okay, so you can just write down that 3 cyst CE3, and along with that you can see another completely anechoic lesion, and this is CE1. Okay. Okay, this is cartwheel sign, because along with the anechoic lesion you can see within that there are some hyperechoic septi. Okay, this is called as the cartwheel sign. Okay, or you can see here this, if picture appears like this, then you can just write down honeycomb appearance. Okay, so this is anechoic. You can see this is black, but along with that there are hyperechoic septi. Okay, so this is basically honeycomb appearance. Okay. Okay, now we will be talking about breast imaging, and these are specific terms that will be very helpful to describe any breast mass. Okay, so please remember these terms while describing, because with every slide I'm not describing accurately. Naturally, I'm just focusing on very important finding, but when you have to write down in your exam, you have to write down the findings in detail, so you can use these terminology. Okay. So this is braces. Okay, actually when we are giving you such type of investigations in which you cannot say that which part we have imaged, so in that case we are providing you a scenario, so that, because naturally if you are giving me this picture, so I cannot say that which part it is. I can say yes, I can see anechoic lesion, well circumscribed anechoic lesion, but I cannot say which part it is. So in that case we are telling you some scenario so that you can understand which part it is. In that case we are not asking you which part it is, because it's really difficult to understand. Okay, so don't worry. दिस इज़ कम्प्लीटली एनीक्विक, नो इंटरनल इकोज. इंटरनल इकोज का मतलब क्या होगा कि छोटे छोटे वाइटिश से पार्ट भी अंदर होंगे, तो इसमें नहीं है. सो दिस इज सिंपल ब्रेस्ट सिस्ट. ओके, Here you can see this is hypoechoic lesion. Okay, this is well circumscribed hypoechoic lesion. Even this is not lobulated. Lobulation abhi main aapko dikhaungi inshallah in the next slide maybe. Okay, so but actually here this is well circumscribed and this is rounded. So benign lesions, these are well circumscribed, that may be rounded or oval. Okay, and this is hypoechoic. Okay, because this is grayish, not very brightly white. Okay, if that is brightly white then we must say hyperechoic, but this is not hyper, this is hypoechoic lesion. Okay, here you can see that there is hypoechoic lesion here and there is anechoic lesion here, anechoic lesion here. Okay, so basically this is simple cyst and this is fibroadenoma and the single breast. Okay, okay, here there is hypoechoic lesion, but this is a bit lobulated. You can see here lobulation. Okay, this is lobulation, so this is lobulated. Okay, but remember that macrolobulation, this is macrolobulation. Okay, macrolobulation are towards benign. Okay, if this is microlobulation then this is quite suspicious. Okay, but here we cannot notice microlobulation, we can notice macrolobulations. Okay, in this actually you can see very angulated. ये देखें, this is not well circumscribed, this is not rounded, this is not oval, margins are quite indistinct. Okay, आपको समझ नहीं आ रहे कि distinct हैं, बिल्कुल पता नहीं चल रहे, but you can see कि यहाँ पे slight speculation है. Speculation means कि ये infiltrate किया हुआ है. You can see, देखें, this is quite different from the previous slides. You can see here, जबकि this is not very well rounded, ऐसा नहीं है, there are lobulation, but even then it is quite different, more angulations. देखें कितने नोकीले हैं, यहाँ पे देखें कितनी नोकिए हैं, है ना. Other thing is that infiltration feel हो रही है. Okay, you can see this is speculated. Okay, ऐसे angles में है और चीज़ें निकल रही हैं, so this is quite suspicious. Okay, and remember that whenever you are describing breast lesion, okay, so you have to accurately tell us कि what are the findings which are towards suspicious. Okay, as I have told you earlier, ये वाली जो findings हमने लिखना सीखी हैं कि malignant में, तो प्लीज़ इसमें से जो है जो भी सूटेबल वर्ड्स हों तो यूज़ दीज सूटेबल वर्ड्स. ओके, कि कौन कौन से आपको, फॉर एग्जांपल अभी हमने जो पिक्चर देखी है उसके अंदर आपको क्या चीज़ें मिली. फॉर एग्जांपल इनडिस्टिंक्ट मार्जिन्स मिले, एंगुलर मिला, आपको माइक्रोलोबुलेशन नहीं मिली जो अभी हम पिक्चर पे बात कर रहे थे, बट दैट वाज स्पेक्युलेटेड. ठीक है, इनहोमोजेनस इको टेक्सचर का मतलब क्या है कि समवेयर देयर इज हाइपरएकोइक, समवेयर इट इज़ हाइपोएकोइक और मे बी आइसोएकोइक. ठीक है, और मे बी इवन एनिकोइक, मीन्स कि आपको एक होमोजेनस पिक्चर नहीं मिल रही है. ठीक है, अच्छा, अभी बाकी हम फाइंडिंग्स देखते हैं. मे बी हम किसी और पिक्चर में हमें ये टॉलर देन वाइडर और माइक्रो कैल्सिफिकेशन एंड इवन माइक्रोलोबुलेशंस मिले. लेट्स सी. फॉर एग्जाम्पल इन दिस पिक्चर अभी हमने क्या बात करी थी, टॉलर देन वाइडर. सो दिस इज बेसिकली, दिस लीजन इज टॉलर देन वाइडर. ओके, और क्या है कि इनहोमोजेनस टेक्सचर है, इको टेक्सचर है. क्यों? क्योंकि कहीं पे यू कैन सी ये थोड़ा वाइटर ज़्यादा है और कहीं पे ये ब्लैकिश ज़्यादा है. ठीक है ना, आप ये देखें, होमोजेनस नहीं मिल रहा आपको, एक जैसा नहीं मिल रहा. जबकि आप देखें फाइब्रोएडेनोमा में ये देखिए कितना होमोजेनस है. ठीक है, यहाँ पे भी काफ़ी हद तक होमोजेनस है. इस हद तक यहाँ पे इसमें देखें, इसमें तो बहुत ज़्यादा, यहाँ पे कहीं पे बहुत ज़्यादा ब्लैक है, कहीं पे बहुत ज़्यादा वाइट है. दिस इज़ बेसिकली इनहोमोजेनस इको टेक्सचर है एंड इरेगुलर है, एंगुलेशंस मौजूद हैं. ठीक है ना, यू कैन सी ये कितनी एंगुलेशन मौजूद है, ठीक है। ओके, इन दिस पिक्चर यू कैन सी माइक्रो लॉबुलेशन, छोटे छोटे ऐसा लग रहा है लॉबुलेटेड है, बट दिस इज माइक्रो लॉबुलेशन। जस्ट रिमेंबर द फाइंडिंग ऑफ द फाइब्रोएडिनोमा, उसमें हमने क्या देखी थी, मैक्रो लॉबुलेशन देखी थी, ठीक है। तो दैट वाज नॉट स्मूथ, लेकिन लॉबुलेशन क्या थी, बड़ी महसूस हो रही थी, बट हियर यू कैन सी माइक्रो लॉबुलेशन। सो दिस इज ऑल्सो सस्पिशियस एंड देयर आर इनडिस्टिंक्ट मार्जिन, आपको मार्जिन क्लियर नहीं हो पा रहा, ठीक है। सो दिस इज बेसिकली अ वेरी सस्पिशियस फाइंडिंग, ओके। mammography, in mammography you have to mention the view, okay, this is craniocaudal view, how we can say craniocaudal view, इसमें होता ये है कि you can see the breast tissue को यहाँ पे रखा जाता है and then pressed from above down, okay, and the picture is like this. So this is craniocaudal view, okay, that is very important that you have to mention whenever we are giving you any mammogram, okay. And this is mediolateral oblique, यू कैन सी कि मशीन को थोड़ा सा ओब्लिक करके एंड देन ओब्लिकली प्रेस किया जाता है, सो दैट यहाँ पर आप देख सकते हैं कि मसल भी आ रहा है, पैक्टोरैलिस मसल नज़र आ रहा है आपको, ठीक है। व्हेन यू कैन सी द पैक्टोरैलिस मसल, सो दिस इज बेसिकली मीडियोलैटरल ओब्लिक व्यू, ओके। and this is spot magnification view, you can see here कि separately एक जो है वो magnifying lens लगा के and then we have just taken the picture. Why? Because when you see some pathology and that is not clear on the regular views, then you can take the spot magnification view so that it is magnified and you can see that what is the pathology. Here you can see a benign pathology, you can compare easily. That this is very well defined, see, while this is not very well defined, okay, you can see speculation, ये इस तरह से जो नोके नोके बारीक बारीक सी निकलनी है, this is called as the speculation. So this is basically speculated, okay, speculated mass है. And along with that if you just focus, there may be some micro calcifications as well, okay, but these are not very clear in this picture, okay. Yes, in this picture micro calcifications are very clear. वैसे जो micro and macro calcification का जो distinction है, actually that is on the measurement. So naturally you cannot measure in your exam, so you can just see that if there are very tiny spots, you can just say that this is micro calcification. You can see here that this is speculated margin, speculations, okay, this is hyperdense speculated mass, okay. In urological imaging, this is simple plain X-ray pelvis, okay, that is showing these hyperdense masses. So these are basically bladder stones, okay. IVU is part of your syllabus that may show different pathologies, okay. Here in this you can see that there is obstruction, okay, because there is completely obstructed and you can see the dilated pelvis, okay. So basically this is showing obstruction, but there may be various pathologies on the IVU we can just give you in your exams, okay. Thank you very much. अल्लाह हाफ़िज़, अस्सलामु अलैकुम व रहमतुल्लाहि व बरकातुहू।